Hello there. My name is Dr. Rebecca Gilbert, and I am Chief Scientific Officer at American Parkinson Disease Association. Thank you so much for joining us today for this episode of Dr. Gilbert Hosts, which is a series during which we're conversing with experts in Parkinson's disease to talk about topics that are of interest to our Parkinson's disease community. So today, we will be discussing Parkinson's disease and gene therapy. And I'd like to thank our sponsors, Genentech and Medtronic, who have given unrestricted educational grants for this session. We're going to answer some basic questions about what gene therapy is and how it can potentially help people with PD. And we are going to answer your questions that you submit via the Q&A box on your Zoom app. Today, my guest who will help us answer some of these questions is Dr. J. Timothy Greenamyre. Dr. Greenamyre has many titles. He is the Love Family Professor, Vice Chair of Neurology, Chief of Movement Disorders, Director of the Pittsburgh Institute for Neurodegenerative Diseases, and the Director of the American Parkinson Disease Association Center for Advanced Research, all at the University of Pittsburgh Medical Center. His laboratory studies mechanisms of neurodegeneration in Parkinson's disease with a focus on gene-environment interactions, and he performs translational studies using pharmacologic and gene therapy approaches. He's authored numerous peer-reviewed papers and offers his expertise to multiple Parkinson's disease organizations, including APDA, since APDA is privileged to have Dr. Greenamyre on our scientific advisory board. So Dr. Greenamyre, thank you so much for joining us today.
Thanks, Rebecca. It's a pleasure to be here.
So first, what we're going to do is have Dr. Greenamyre give us an overview of what gene therapy is, what research is taking place using gene therapy to try to help us understand or treat Parkinson's disease, and give us some flavor about whether this research is promising and the directions of the research. And again, when Dr. Greenamyre is finished with his introduction, we are going to ask Dr. Greenamyre the questions that you have either submitted earlier when you registered or that you submit now using your Q&A tab in the Zoom session. And so without further ado, I will turn the presentation over to Dr. Greenamyre for an introduction of gene therapy. Dr. Greenamyre.
Thanks, Rebecca. So everybody's on the same page, and I know everybody has different knowledge and different experience. I wanted to go over what gene therapy actually is. So starting out with what is a gene, we all know that we have chromosomes that are composed of DNA, and we have thousands of different genes that instruct our cells to make different proteins in a particular cell at a particular time. And a gene is just that piece of DNA that gives the instructions on how to make a particular protein in a particular cell at a particular time. So that leads to what is gene therapy. And gene therapy is basically a way to replace a gene that doesn't work properly, or a protein that is deficient or mutated so that it doesn't function properly. Or another kind of gene therapy is a way to turn off a gene that's abnormally active, or reduce a protein that's abnormally abundant. So in other words, if you have a gene that's misbehaving and doing bad things, you may want to turn that gene off or reduce its activity. Or if the gene produces a protein that's toxic to your cells, it's a way to reduce that toxicity. So gene therapy can be, or can come in a number of different flavors, as I say. If we want to augment or replace a gene, we typically take that genetic material, the DNA, and we package it into a harmless virus that I'll explain in a minute, and we inject that directly into the brain. On the other hand, if we want to turn something off or turn it down, we usually use something called an antisense oligonucleotide, or an ASO to be brief. And we deliver that typically by a spinal tap or some other way to get it into what we call the cerebrospinal fluid that surrounds the brain and the spinal cord. Next slide, please. So this is a quick diagram of how gene therapy works. We take the missing gene and we use molecular biology techniques to correct that gene or create that gene. Then we package it into a virus. In this case, the slide is showing a virus that's commonly used in gene therapy trials called adeno-associated virus that has been rendered harmless to the brain. It doesn't cause any infection in the brain in terms of toxicity. Then we deliver that virus directly into the brain, usually using an injection with a needle and an operating room procedure. And then it takes a period of months for that gene to start acting the way we expect it to, and we start looking for beneficial effects. Next slide. So this is just another diagram of that. We take the genetic material shown at the bottom and we insert it into the virus, and then we inject it into the brain to have it work. Next slide. And one of the advantages and potential disadvantages of gene therapy is that we have to inject it typically directly into the area that we want it. So this is very good for targeting, for example, the dopamine cells that degenerate in Parkinson's disease. But if we want to have an effect throughout the whole brain, then it becomes more problematic because we can't inject throughout the whole brain. We can only inject once or twice into a specific area. Next slide. So there are advantages and disadvantages to gene therapy. When we use a virus to deliver the gene, we can target it to the specific brain region and maybe the specific cell type, like the dopamine neurons that we want to target. And because it's directly injected into the brain, we don't have to worry about an issue that plagues us with certain drugs. The brain is surrounded by membranes called the blood-brain barrier that make it very difficult to get certain drugs or molecules into the brain. But that's not a problem if we're directly injecting the therapy into the brain. In addition, as opposed to drug therapy, where you have to take a pill every day or multiple pills every day, gene therapy may be what we call a one and done therapy. If we inject and correct the genetic defect, a single treatment may be sufficient. This raises problems, of course, with how the companies that make these gene therapies are going to bill something. If they have a therapy that can correct or stop the problems with Parkinson's disease, how do they charge for something that costs them millions of dollars to, or billions of dollars to develop, but one procedure fixes it? So it's an ongoing and evolving topic of discussion. There's disadvantages to gene therapy because it can generally be permanent. So it can be a good thing, but it's a bad thing if there are side effects because there's no way to turn it off. The other issue is that Parkinson's disease, as most of you know, affects not only the brain, but various parts of the body like the GI system. So delivery to a small region injected into the brain may have limited impact. It may only affect certain symptoms and not other symptoms, and so it has limitations. Next slide. Now, the other kind of gene therapy to reduce an abnormal gene that's causing toxicity with antisense oligonucleotides, or ASOs, has certain advantages because they can affect widespread areas of the brain and body. It's just a matter of how they're delivered that they can do this. And the effects of each treatment infusion, whether it's by spinal tap or other mechanisms or ways of delivery, can wear off over a period of months. So the effect is not permanent, and that's good if there are side effects because it won't be a permanent side effect. But this leads to disadvantages too, because each of the treatment infusions does wear off over time. So the effect isn't permanent, and if there are no side effects, it means that this is bad because it requires repeated ongoing treatments. So these are all things we have to weigh, the good and the bad, the pros and the cons, when we're considering what kind of gene therapy to propose. Next slide, please. So gene therapy can fall into two general kinds of buckets in terms of what we're trying to achieve. One can be that we're trying to treat the symptoms, much like Sinemet or levodopa or other drugs that we currently use in Parkinson's disease treat the symptoms. They don't affect the ongoing disease process, so the disease continues to get worse over ongoing years. So these are strategies that would treat the symptoms much like levodopa or a dopamine agonist like pramipexole would. One therapy is called glutamic acid decarboxylase, or GAD, and it's an enzyme that increases the production of a neurotransmitter chemical called GABA. And the idea was to increase the GABA to help restore the normal firing patterns in the brain. That trial has already been completed and didn't really have as much impact as we wanted, and so the trial did not lead to further development of that particular gene therapy. Another ongoing trial that we'll talk about a little bit more perhaps is AADC, or aromatic amino acid decarboxylase, which is an enzyme that's very important in making our levodopa, which is contained in Sinemet, make it work by converting it to dopamine. So without AADC, levodopa would have no benefit. It has to be converted to dopamine. And the goal is to increase the amount of AADC to augment that protein and gene and make levodopa treatment more effective and longer lasting. Very similar to AADC is a more complicated gene therapy that's also ongoing for symptoms, and that combines three genes, one for AADC, one for something called GTP cyclohydrolase, and another for tyrosine hydroxylase. And the basic idea is the same. These three enzymes are very important in the production of dopamine in the brain, and the goal is to increase dopamine production and have it last longer. Next slide. Then the other bucket, or the other reason for doing gene therapy, other than treating the symptoms, is to modify the disease course. As this is sometimes called neuroprotection. And the idea here is to pick a strategy that will stop or slow the disease from getting worse. So one strategy is to increase the amount of an enzyme called glucocerebrosidase, or GBA, which is a common genetic cause of Parkinson's disease. But the idea here is to inject this gene into the brain and have increased production of this enzyme, which we hope will restore normal function and decrease the toxicity of another protein called alpha-synuclein, which is one of the major components of Lewy bodies that most of you have heard of. Then there are a couple of growth factors, or trophic factors, that are under investigation. One is called nurturin. It's a nerve growth factor to support the survival, or in some cases maybe even rejuvenate sick nerve cells or neurons. Another similar growth factor is called glial-derived neurotrophic factor, or GDNF, which has been tried in a variety of ways in Parkinson's disease. You may have heard of GDNF trials in the past where they were actually infusing the GDNF factor into the brain directly, but those were very controversial and overall not as effective as we would have hoped. This is to actually make the brain make more nerve growth factor instead of infusing it directly into the brain. And finally, there's an ongoing, very new trial to downregulate or decrease the activity of an enzyme called leucine-rich repeat kinase 2, or LRRK2, which is another common genetic cause of PD. And the idea is to knock down its overactivity and protect neurons. Next slide. So this is a summary of the ongoing gene therapy trials that we know of currently. Some of these are still recruiting, and they mostly fit into the bucket of, or they fit into both buckets of disease modification as well as symptomatic treatment. So the first one, the trial is called Sunrise PD, and this is the trial of the 3 enzymes together to increase dopamine production in the brain. This is what we call a phase 1 or 2 trial. It's very early in the development of this trial, of this strategy, I should say. And it's mostly looking at safety and tolerability of this intervention. The next trial is the GDNF gene therapy trial. And this is a phase 1 trial that is simply looking at safety and tolerability. So that means that it's not looking at whether this drug is effective in stopping the disease yet. Similarly, there's the PROPEL trial, which is looking at the enzyme called glucocerebrosidase, or GBA. And that is also a phase 1 and 2 trial. So it's looking at safety and just beginning to get glimpses of whether it might be effective in the disease. There's the AADC trial called RESTORE-1. And this is a symptomatic trial trying to make the brain make more dopamine in response to levodopa doses. And the primary thing that they're looking at is whether this can reduce the amount of off time that patients have and increase the amount of time that the levodopa is working effectively. And so this is one of the few trials that's listed here that is actually looking at the beneficial effects of the intervention. And the last trial is called REASON, and this is the LRRK2 or leucine-rich repeat kinase 2 intervention to try and reduce the activity of this enzyme and protect the brain. But again, this is primarily looking at adverse events and safety in this trial. So with that, I guess we can get to the question and answer.
All right, that was fantastic. An extremely clear overview about gene therapy and practically what is going on in the field right now. Questions have started to come in, and one of the main questions is, so here's a list of our 5 clinical trials that are open. If I'm a person with PD, I'm interested in these trials, what steps do I need to take to enter a trial? What are the suggestions you have?
Well, if you're uninitiated, it's hard to find the trials and figure out how to get started into them. There are 2 big resources that I would suggest. One is called Clinicaltrialsgov, and you can search in that web page for Parkinson's disease, and you can see all the different trials that are available in Parkinson's disease. But it's a little bit hard to navigate that website for the uninitiated. There's another instrument or resource that's available called Fox Trial Finder that will take you through a series of questions related to your particular case, your symptoms, and so on, and now help you navigate towards where the trials are located and where the contact people are and who's eligible and who's not eligible and that kind of thing. So I think those are the first steps to take.
I would also point out that you included in the slide these NCT numbers, and these are the numbers that correlate to the particular web page on clinicaltrials.gov of the different trials that are listed here. So more information about each trial can be obtained using this number. And anyone who wants a copy of these slides, you can reach out to us when you receive your email at the end, and we can send you these slides. I'm going to actually stop sharing the screen so that we can see you a little better. The next question that you began to address, but just to address it more formally, will the use of gene therapy be subject to all the phases of clinical trials similar to the way in which drugs are reviewed prior to approval?
Yes, gene therapy will go through the same kind of approval process. So there's phase 1 trials that look at safety primarily, adverse events, and that kind of thing. So you all heard about the COVID-19 trial, that vaccine trial that just got stopped because of a serious adverse event. That's what people are looking for in these phase 1 trials. Phase 2 trials are designed to look at whether the drug or gene therapy is effective, but these are small trials just to give a hint about whether they're going in the right direction or not. Then the really crucial phase, if a drug makes it through the other phases, is a phase 3 trial, which typically involves thousands of patients and costs tens of millions of dollars. And so it's a long process, and there are many failures along the way, but gene therapy has to go through all the same processes.
Okay, great. One question that came up a number of times, both now and also previously when people registered, was, what are your thoughts on what the best stage of Parkinson's disease would be once the gene therapy is approved? Would it be better for early stage or for advanced PD? What do you predict?
It really depends on the kind of therapy that you're talking about. If you're talking about something like the AADC trial that I talked about, that is designed to make levodopa more effective and last longer and reduce off periods, you have to wait at least until the stage where you're already taking levodopa and when you need levodopa. So it's disease that's already manifest, that you already have symptoms from and are having complications from. On the other hand, if you're looking at something that's designed to slow down the disease or stop it in its tracks, then the earlier the better. One of the limitations we have right now for these trials is how early we can diagnose Parkinson's disease. So we typically have to wait until people develop the classic motor symptoms of Parkinson's, like tremor and rigidity and balance problems and slowness. We know that their disease has been going on for a long time by the time they get that diagnosis. So we're continuing to look for early ways to diagnose people before they develop motor symptoms. But the earlier the better for disease modification.
So you could imagine a day where people are diagnosed very early, before motor symptoms, and potentially get gene therapy at that point. Is that what you're suggesting?
Exactly. The other issue that's kind of related to that is, I think most people would say that at the earliest stage that they got diagnosed and began to need medicine, if they do need medicine, that if we could stop the disease at that stage, keep it from getting any worse, that their quality of life would still be quite good. So, you know, short of a cure, if we could stop the disease or really slow it down at the earliest stages, then we'd have a real success.
So 2 questions related to the phases of the trials. One person is curious about what phase the Restore trial is in specifically. And another question is, are any of these trials already in phase 3?
None of the trials are in phase 3 at this point, no. The Restore trial is in phase 2 at this point. So they're looking at signs of efficacy.
Great. Another question that came up a whole bunch of times is, if I have gotten DBS already, deep brain stimulation, would I be eligible to participate in a gene therapy trial or a potential gene therapy treatment once that's available?
The second part first. There's no theoretical reason why, if you've had DBS, you couldn't have gene therapy. But on a practical basis, while trials are ongoing, they have to have participants in the trial who have not had other surgical manipulations or permanent therapies like DBS. So if you've had DBS, you're not eligible for a gene therapy trial, to the best of my knowledge. But once the gene therapies are on the market and available, there's no reason why you couldn't get it. But that's years down the line.
Got it. We have questions rolling in. Here's a good one. Are the symptomatic therapy, you divided up the different gene therapies into the symptomatic ones and the disease modifying ones. When a person is actually in the trial and receiving the treatment, is the actual procedure the same? Are there differences in how those two trials are conducted? Or the person receiving it would not kind of sense any difference?
Theoretically, they could be exactly the same. The outcomes and what's being measured are a little bit different. For a symptomatic treatment, you're looking at some particular symptom that you can measure, whether it's tremor or slowness or on time or off time, those kinds of things. For a disease modification or neuroprotective trial, you're looking at things over a longer time scale, and we use certain rating scales to determine the stage of a patient, or we sometimes use PET imaging or DAT scans to look at progression. And we use those as markers for how things are changing over time for neuroprotection versus symptoms. So the actual therapy can be administered the same way for both kinds of trials. What's being measured at the other end of the trial is a little bit different.
Okay.
Did that answer the question?
Yes, I think it does.
Okay.
Many people have asked some version of this. What, in your opinion, is a likely timeline for sort of the first one out of the gate, first gene therapy trial out of the gate to be approved for use?
That's a great question, and I wish I had a great answer. I don't know. I would say we're at least 5 to 7 years from having something approved. I would guess. The exception might be the AADC trial, which is farther along and is now in phase 2. Assuming it continues to show positive results, which it has to this point, it may go into phase 3 within a year or two, and we might have something ready for approval within the 5-year timeline.
Okay, fantastic. Another question that we've gotten in various forms: are there gene therapy trials in other countries that are more advanced than in the US?
The trials that we've listed are international. The one trial at Oxford, I don't remember the name of it. It was the first one listed with 3 enzymes. That one is in the UK and France, I believe. The other trials are mostly in the US, but the LRRK2 trial called Reason is international. It's US, France, Spain. There may be other countries involved as well.
Got it. So any of our international listeners or viewers right now may have access to these trials as well, and there aren't other trials sort of floating out there, as far as we're aware, that they would have access to that US people do not.
And the Clinicaltrialsgov website tells you where the trials are located.
Okay, we have an excellent question here, which is, where does the injected material come from? Does it come from a live source? Is there any chance of rejection? And here, I think the maybe you can address, which is a issue that's come up in many of the questions, sort of stating the difference between gene therapy and stem cell therapies, which people tend to confuse a little bit. So perhaps you can address that as well.
Okay. So the genetic material is made in a lab, in a test tube, basically. It's identical generally to what's in the brain. So the genetic material is not rejected. The viruses are harmless and generally don't cause any kind of reaction. They're designed and engineered to do that. There's a theoretical risk that the viruses could cause an inflammation, an inflammatory response, and that could cause problems. But so far, the viruses that have been used have been quite safe. Gene therapy is just taking essentially a biological molecule, a large chemical, DNA or something closely related to DNA, and using that. Stem cell therapy actually uses cells that are derived from various sources, often from the individual patient who has the disease. And they're manipulated and re-injected. So if the stem cells come from a different source or a different person, there's a theoretical risk that they could be rejected after injection. If they come from the same person, that is the individual with Parkinson's disease, gives cells that are then genetically manipulated and then re-injected into their system, there's very little chance of rejection because it's their own cells. So it depends on the source of the cells and whether you're injecting cells or genetic material as in gene therapy. So they're a little bit different.
So to answer the person's question, in a different form. So what we're discussing today primarily is gene therapy, where you're injecting viruses with manipulated genes. We're not injecting cells. Injecting cells is a sort of different strategy, and those two are often confused because they both involve injecting things in brains, but they are two quite separate strategies, and different groups of researchers are working on those two strategies. So here we're looking at the genetic material inside viruses. So we have a whole bunch of questions addressing a similar topic, which is all these trials seem to be specific for Parkinson's disease. Is there any hope of gene therapy for what are called the Parkinson plus syndromes or related neurodegenerative diseases such as multiple system atrophy or progressive supranuclear palsy? Any gene therapy trials on the horizon for those type of diseases?
I'm not aware of gene therapy trials for MSA or PSP or related Parkinsonian syndromes. There's no theoretical reason why it can't be done. I think people are targeting the more common diseases initially. But there is work on trying to protect the brain in diseases like PSP and MSA, just not using gene therapy. So there are approaches drugs that have been tested in PSP, and there's a recent article out looking at the safety of a immunotherapy for MSA to try and reduce the levels of a toxic protein called synuclein. And so far it looks safe, and so they're going forward with that. So there's certainly hope on the horizon for these diseases, but it's a little lagging behind Parkinson's disease, probably.
Okay, we have an amazing question here, which is, how do researchers decide which genes to target in gene therapy? Where did these 5 strategies come from?
They come from a variety of sources. Lately, we used to think that Parkinson's disease had no genetic component whatsoever, that it was just sort of bad luck that you got it. But now we recognize that there's a lot of genetic factors that go into Parkinson's disease as well. And so some of the gene therapies are based on genes that we know that when those genes are mutated and functioning abnormally causes Parkinson's disease. We take those clues and test them in animal models of Parkinson's disease and look for signs that they're effective there, and then translate them into therapies for people. So some of it comes from what we know about the genetics of the disease. Some of it comes from what we know about the basic biochemistry and cell biology of Parkinson's disease. So some of the trials, particularly the ones that are trying to restore dopamine, come from decades of research where we know the different pathways that produce dopamine and the enzymes that are necessary for that. And we try and restore that with the different strategies that were outlined in that table. Some of the strategies that we develop come from what we know about what causes nerve cells to die in Parkinson's disease. And we try and find the key steps in causing cells to get sick and die that we can target for therapy, and test them again in first cells in a dish, and then animal models, and then ultimately, if that's looking promising, then we try it in humans.
Okay, great. And so the bottom line is that more strategies are possible if more research is done. So the basic research has to happen first, and then people can translate that knowledge into a potential gene therapy strategy. Actually, that reminds me that we had a question that I wanted to answer, which is, we mentioned that you do translational trials in your lab. Can you define translational trials for us?
Yeah, so there's a difference between what we call basic research and what is clinical practice. And for years, scientists studied cells in a dish or animal models of disease, and we're working out the mechanisms, the pathways that lead to cell death, for example, and leaving it at that. And there was no translation of that knowledge into clinical practice. And so what we've tried to do in more recent years across the world is translate that basic knowledge that comes from cells in a dish or animals in the laboratory to something that might be useful clinically. So we take these mechanisms that we define in the lab and target them for therapy using approaches that we think will ultimately be useful in clinical practice, such as gene therapy or small molecule drugs that might be efficacious or effective in clinical practice. So translation is the critical bridge between basic scientific knowledge and clinical practice.
Great. And so gene therapy is a perfect example of that. We have a great question here. When a gene therapy a trial does enter phase 3 and there needs to be many more participants than are recruited for phase 1 or 2, do you foresee that the actual surgery of injecting something in the brain will cause difficulty recruiting volunteers? What is your experience with people agreeing to that type of trial?
I think it's very individualized. And I think it depends on the therapy and the potential of that therapy. I think that there are people who are naturally and logically reluctant to have their brain operated on for a therapy that is only going to have modest benefit. But if you have a gene therapy, for example, that has the potential to slow down or stop the disease in its tracks, then I think the equation gets shifted a little bit more towards willingness to participate. But it's a very individual decision, and it depends on the risks and the benefits and the actual procedures involved. I think another aspect of this is whether the particular flavor of gene therapy or whatever therapy is one and done, one therapy, one injection into the brain, or whether it requires multiple injections by spinal tap, for example. That may scare some people off, but not others. There's a trial ongoing, not for gene therapy, but for another way to lower alpha-synuclein levels that we've been involved with. It involves multiple spinal taps, and we haven't had any difficulty recruiting for that. So it really depends on the motivation of the patients and how the research is explained to them and their knowledge level and so on.
Excellent. We got a few questions about this new technology called Crispr technology that has made the news for various conditions. And is there any, or could you explain what that is and talk about the differences between your thoughts on using this type of technology for Parkinson's versus a gene therapy approach?
Yeah, CRISPR technology is a way to do what's called gene editing. So gene therapy, the way it exists right now, is we're not changing the genetic defect in a person. If a person has a defective gene that is not producing the protein that it's supposed to make, we can replace the gene, but they still have the abnormal gene in their brain. CRISPR technology is a way to correct the gene in the cells in the brain rather than injecting another gene to replace it. It's a complex but evolving technology. I think it has potential for genetic diseases that we can predict before birth. We can CRISPR engineer the egg or the embryo potentially, and the technology for that kind of thing exists, although there are obvious ethical questions that surround this. To do this in an adult brain is much more complex, and I don't think we have the technology to do that right now, but it is an evolving technology. It's evolving rapidly, and I think it holds a lot of potential. It's just not ready for prime time right yet.
There's so much potential out there, and we're excited to see what happens next. We have a great question that came in that I think will highlight maybe some of the questions people have. You mentioned that gene therapy needs to be targeted and needs to be injected in a very specific location. How does that location relate to where Lewy bodies are? And is there any benefit in knowing where a person's Lewy bodies are to potentially target those?
Yeah, that's a great question. For those of you who are unfamiliar with Lewy bodies, they're clumps of abnormal clumps of protein that accumulate in certain cells in the brain in Parkinson's disease and Lewy body dementia. Excuse me. They are composed largely of alpha-synuclein, another protein that the brain makes, and which clumps and causes toxicity in the cells. In Parkinson's disease, much of the Lewy body pathology is contained in the dopamine neurons in a small area called the substantia nigra. So that's targeted for some of the therapies that try and reduce Lewy bodies or reduce alpha-synuclein protein. And we expect that will be helpful for protecting those dopamine neurons. But we know that alpha-synuclein and Lewy bodies accumulate more widespread distribution, and areas like the cortex, which control our thinking and our memory and our general cognitive function. And right now, injections into the brain to target gene therapy couldn't target all of those areas simultaneously. It'd be too many injections and impossible to do. However, the antisense oligonucleotide approach that I described with the ASOs gets more widespread distribution and could knock down the alpha-synuclein levels in a more widespread fashion, including in the dopamine neurons in the cerebral cortex and other areas that are involved in cognitive dysfunction and even GI dysfunction. So it depends on the specific therapy, but I think targeting the cells that accumulate Lewy bodies is one of the things that we're very interested in.
Fantastic. On that note, I think we have to wrap up. We have a whole bunch of unanswered questions, and I will try to get to those questions so that everyone gets a response to what they've asked. So tune in to your email later and over the next few days. I wanted to thank Dr. Greenamyre so much for his expertise to introduce us to the topic of gene therapy and give us some hope about the 5 available clinical trials that are not yet in phase 3, but in phase 1 and 2. And so there's a promise there for 5 different strategies with more to come as more research is done. And to give us some sense of how these therapies are performed and what potential outcomes we could hope from these different therapies. So thank you so much for that fantastic introduction to this topic that I'm sure we're going to hear a lot about over the next few years. Now, anyone who's listening today who may want to revisit this session, we are going to be archiving this, and it will be on our APDA YouTube channel over the next few days. So please feel free to share that link with anyone who you'd like to, or to see it again yourself. Also, I'd like to note that please consider donating to APDA so that we can continue to bring you this type of programming that answers the questions that you have. And you can do that by, again, going to our website, which is apdaparkinson.org. Our next Dr. Gilbert host session will be on Monday, October 19th, and that's at noon Eastern Standard Time. And at that point, I will be conversing with Liana Marie. She is a PD caregiver and advocate. She was a care partner for her mother for over 30 years and has written a couple of books about her experiences, and is a blogger and basically a social media influencer. And we're going to be discussing with her the challenges and rewards of being a PD care partner. So please join us then again on Monday, October 19th. So until then, thank you so much for joining, and we hope to see you again very soon. And thanks again to Dr. Greenamyre.